So I want to thank everyone for coming today. I guess it's a pleasure for me to introduce our speaker, Dr. Barry Borlaug. And Barry is Professor of Medicine and Director of Circulatory Failure Research in the Department of Cardiovascular Medicine at the Mayo in Rochester. He's an active clinical investigator interested in the fields of heart failure and pulmonary hypertension, with particular interest in hemodynamic underpinnings of cardiac disease and exercise physiology. And he's currently working to better understand the causes and mechanisms of heart failure and pulmonary vascular disease. And he's active in a number of clinical trials, developing and testing novel medical and device-based therapies to improve outcomes for people with heart failure. So that's Barry's little bio that he gave me, but I'll give you the real bio now.
Right.
So Barry
completed
his medical degree at University of Wisconsin. Then he did an internal medicine degree at Harvard at the Brigham and Women's. Pretty impressive, Barry. And then he went to Hopkins, if that wasn't good enough, to do his cardiology training with David Cass, who's one of course, the world leaders in cardiac physiology, hemodynamics, electrophysiology, everything basically. David's the world leader. Barry has a number of fellowships. He's on an editorial board or a guest editor for Circ Heart Failure, European Heart Journal, JACC Heart Failure, Journal of Cardiac Failure. He's mentored over 15 trainees and fellows, and these names are huge names, Carolyn Lamb and others who are editors for Circulation. So very impressive. All his trainees are world researchers, and of course Barry is internationally recognized, invited to speak at AHA, ACC, the transplant meetings, Heart Failure Society of America. He's the keynote speaker every session. You'll see Barry's name. He's a prolific researcher. I looked at his CV today, all 60 pages, and my printer ran out, Barry, so I had to stop. But he has, if I counted correctly, over 60 funded grants as a PI, program director. 24 are ongoing, 36 are completed. And he's got a currently funded R01 looking at inorganic nitrate and to enhance the benefits of exercise. So some of Barry's work, some of the seminal work he's published on the mechanisms underpinning exercise intolerance, and he uses invasive measures during exercise, and he's one of the few people in the world who puts catheters in people's hearts while they're exercising to uncouple some of the heart, the lung, and muscle and blood flow perturbations. Since 2005, he has over 200 publications in New England Journal of Medicine, JAMA, Circulation, European Heart Journal, a bit of an underachiever. And so Barry, it's just been a pleasure for us to have you here today. I know it's a very, very short visit, but we really look forward to your talk and your visit. And we've also had the fortunate pleasure to have Kate with us as well, his wife. Barry told me he totally married up. So Kate is completing her PhD at University of Minnesota in kinesiology, and very interested in the research that a number of us are doing with the physiology of obesity paradox, and HFpEF. So she's had, I think, a very good morning as well. So we really appreciate both of you being here, and we look forward to your talk, Barry.
Thanks, Mark. No, it's thank you. Kind introduction for having me and having us here. It's really been energizing for me to meet with many of you and look forward to more after this. I mean, this is really, when you guys are farther along in your training, you get invited to go somewhere. Initially, you're just so floored that somebody asked you to come, and you're excited, you say yes, and then it gets close to the time where you're going to go. You're like, oh, I got to get that together and get a flight, and you're kind of reluctant, but then you go, and you go to a great place like this. You're so happy that you did, because you're just like, you're building relationships or improving older relationships, and you're energizing each other, and it's really what it's all about. It's such a team sport, science, so it's really been great. It's been fun. So I'm talking about heart failure with preserved ejection fraction, or HFpEF, which we used to call diastolic heart failure. And I didn't include, these are my disclosures, I didn't include a lot of kind of the basic background, not thinking that there's a lot of people that maybe aren't MD or clinical. So let me just kind of review. So heart failure affects 6 million Americans, 15 million Europeans. About half of all people with heart failure actually have a normal ejection fraction. So their heart squeezes out a normal amount of blood per heartbeat. The other half is like the more classical heart failure, weak heart, can't pump blood. So that's the disease I'm talking about. So it's about 3 million Americans. It's a huge problem. It's growing. It's associated with aging, obesity, diabetes, and there's no proven treatment. Okay, so just kind of that's the basic background so that we're all on the same page. I'd like to talk, despite the fact that HFpEF is very common, there's a lot of controversy of how we diagnose it and how we define it. So I'm going to talk a little bit about that first. And then I'm going to spend more time talking about the pathophysiology and some novel treatments that our group and others are looking at that are sort of geared towards the pathophysiology and how we should be thinking about different phenotypes or different forms of heart failure with preserved ejection fraction or HFpEF. So what is it? This is an interesting question. You'll get lots of different answers to this. What is HFpEF? I define it, I like to use objective measures to define it. So it's an inability of the heart to pump blood to the body at a rate commensurate with its needs, or to do so only at the cost of high filling pressures. That's what your heart's supposed to do. It has to pump blood out to the body, and it has to keep the lungs dry. How do we make this diagnosis? We look for objective evidence of these things. So we look for evidence of high filling pressures, and you can do that on physical examination, distension of the jugular veins, extra heart sounds. You can do it with chest x-ray. You can do it with echocardiography, indicators of high filling pressures. But a lot of times this stuff is equivocal, and you need to put catheters in the heart and blood vessels to make those measurements directly. And that's the gold standard. That's a cath. We also look for evidence of inadequate perfusion of the body, cardiac output, and you can do that non-invasively using cardiopulmonary exercise testing, or you can use it, again, invasively as the gold standard with catheterization. We also need to exclude other things that can mimic this, and we won't talk as much about that. So very important, so if somebody's short of breath, they come into the clinic, I'm short of breath, and you get an echocardiogram, and their EF is low, it's easy. They have HFrEF, systolic heart failure, you're done. But if they've got a normal EF, it's not so easy. And there have been guidelines that have been devoted to kind of make it easier for people. So this is one that's been advocated by the ESC, the European Society of Cardiology. And you look at all these clinical factors, you measure their BNP levels in their blood, you do an echocardiogram if they've got some structural changes in their heart, the left atrium is a little big, this high EE prime ratio, then they have HFpEF. We've tested this. It really doesn't work. It's pretty specific, but it's very poorly sensitive. It misses 40% of people with invasively proven HFpEF. So let's look at a case. This is a very typical patient I see all the time. 70-year-old lady. She's got lifestyle-limiting dyspnea. She's got some risk factors of hypertension, but she's never been admitted for pulmonary edema. And you examine her, and she looks pretty euvolemic. So she doesn't have edema, she doesn't have jugular vein distension, she's got normal BNP. You do an echo, and there's some evidence, some hints that there's diastolic dysfunction. The atrium is a little bit big, but it's really not enough. And you apply that algorithm, and it says it's not heart failure, but the patient doesn't feel good. She wants more than that. What do you do? Well, in our laboratory, this is the kind of patient we do a stress test on. We put catheters in, and we take them to the so-called table of truth. The cath lab doesn't lie. You put catheters in there. It's like a lie detector test. We get answers. Yeah. So we do that, and this is what we saw in this woman. So the red is her LV pressure, and then the black one is her pulmonary capillary wedge pressure, which is like her left atrial pressure. Normally the heart can fill to a large volume with minimal increase in pressure. So these are normal, seemingly reassuring, but she's not symptomatic at rest. She's symptomatic when she does stuff. And when you do exercise, you increase the demand on your heart dramatically. So we need to stress her during that. And when we do this 40 watts of exercise, which is, I'm almost doing 40 watts, just kind of standing up here talking really loudly. So this is what happens. Now her wedge pressure in black is 40, and her LV end diastolic pressure is very high. And that increases the hydrostatic pressure in her lung capillaries, makes her short of breath. So she has HFpEF. She has euvolemic, well-compensated HFpEF, but she has HFpEF. And we've shown that when you take patients like this to the lab, normal BNP, normal clinical exam, pretty vanilla echo, a little over half of those patients will show hemodynamic derangements that are diagnostic of HFpEF, but you really need to stress the system to bring it out. Just like you do with coronary disease. You need to do stress testing to identify coronary disease. You need to stress the heart to find heart failure, and when it's more advanced like that, or when it's less advanced like this. So some groups, especially for clinical trial eligibility criteria, said, well, you have to have a high BNP. BNP is a blood test that's related to how stretched out the heart muscle is. And it's been said that, if it's below a certain cutoff, like 125, it's excluded. But we've shown that 18% of people with proven HFpEF have BNP levels that are that low. Other cutoffs that have been advocated for, 200, that's 30% of patients. 300, that's 40%. So really, we're missing a lot of people if we rely on this blood test. And we know that people with obesity have much lower levels of BNP. Obesity is the biggest risk factor for HFpEF. And then people that have normal filling pressures at rest but only goes up during exercise, you would expect that their BNP levels also wouldn't be as high. So we're missing a lot of these people. Another thing that's been looked for and is useful is this E to E prime ratio, which you get by echocardiography. It's just the ratio of mitral inflow velocity to the tissue annular velocity, so it's an echo index. As this ratio goes up, it's an indicator that your filling pressures go up in your heart. And we tested this, and you can see that there is a relationship here. As EE prime goes up, filling pressures are going up. You can see there's a fair amount of scatter. The R value, it's very significant, but it's 0.6, so it's sort of modest. But it's related. If you do a comparison of people with HFpEF and non-cardiac dyspnea, that's NCD, you can see these two distributions of data are very different. You do an ANOVA on that, the p-value is very significant. But there's also a lot of overlap, especially in this lower range. There's lots of people who truly have HFpEF, but their EE prime, at least at rest, is normal. So that's not, it's useful when it's high, it's specific, but it's not very sensitive. Another thing that we found is that many patients with HFpEF have atrial fibrillation. And people think of atrial fibrillation is when you lose normal sinus rhythm and the atrium is just firing like crazy. We used to think well, you can get short of breath from that, but maybe people are short of breath and they have myocardial disease and heart failure and they get AFib from that. So is the AFib the cause of HFpEF, or is it the consequence of myocardial dysfunction? So to get at this, we looked at a huge series of patients who had all undergone this invasive exercise testing. We had cases and we had controls, and we looked at how many patients had AFib. And if you do that, you make your 2x2 table, you can determine what the odds ratio is for HFpEF. If you have dyspnea, a normal EF, and paroxysmal AFib, your odds ratio for HFpEF is 7. If you have permanent AFib, it's 38.6. You could almost take it to the bank. If you're in AFib, you have a normal EF, and you're short of breath, you probably have HFpEF. And everybody's missing it. And some people, especially in Europe, they'll say they have symptomatic AFib. No, they have HFpEF that also has AFib. It's all how you look at it. So this is a very useful indicator. So how do we approach treatment? I've been really thinking a lot about this. Because we can't cath everybody, unfortunately. I'd like to, but it's not feasible. There's cost, there's very, very minor risk, but there's cost, there's expertise, there's equipment. So you want to apply gold standard tests when it's equivocal to people where the pretest probability is kind of in that intermediate range. How do you determine somebody is in that intermediate range of pretest probability? In order to get at that, we looked at our huge series of patients where we had definitively proven HFpEF and definitively excluded HFpEF. And then we looked at simple clinical predictors that would identify them, and we did a logistic regression and found the independent predictors, and these are the 6. We tried to make it into an easy point scoring algorithm that could be applied in the clinic. So being obese, strong predictor, 2 points. Being hypertensive on 2 or more antihypertensives is a point. Having the AFib, like I mentioned, that's a big one. That's 3 points. There's 2 findings from echo: high PA pressure, high EE prime ratio, and then being over 60. So you just tally these up. So these are available to almost everybody. And this is the probability, the post-test probability of having HFpEF. You can see here as that score goes up, the likelihood gets very high. So we derived this in a population, and then we validated it in another population. This is the calibration curve. So the white box is the actual prevalence of HFpEF in people that had that score, and then the gray box is what our model would predict. And when those agree pretty good, that indicates good calibration. And you can see that people here with very low scores almost certainly don't have it. People with scores 5, 6, 7, 8, 9, 90%. I think you can take that, you can be pretty confident that that's HFpEF. These people that are intermediate here, that's maybe the people we need to do an exercise cath or maybe an exercise echo or something to refine our idea here. But you can see that the validation cohort, the area under the curve is even better than the derivation cohort. So this works very well. So this is in review right now, but this is something that we think can help us in determining how to make the diagnosis. Okay, so I'll stop. That's my sort of ideas on what it is and how we make the diagnosis. Let's turn more on treatment and pathophysiology and how that relates to treatment. So I'll just start and say we don't have anything other than exercise training maybe. We have no pharmacologic therapy that's really been shown to be effective. So what do? Right now we're focused really on filling pressures. That's one commonality, is that increase in filling pressures at rest or on exercise. It's a key driver of symptoms, and this is some data that's in review right now. We know that if you compare to controls in black, people with HFpEF have a very exuberant increase in filling pressure. So as that blood is being squeezed back to the heart, they've got diastolic dysfunction, they've got inadequate suction, that pressure, it can't handle that increase in volume without an increase in pressure. What does that do? Well, it leads to a greater perception of dyspnea, so you can quantify that by the Borg perceived dyspnea score, and you can see that at peak exercise, people with HFpEF reach the same peak dyspnea as anybody else. I mean, I get short of breath. When we're going up the fourth floor, I was getting a little short of breath. But the point is they're getting it at a much lower level than a person normally should. That's related to how high those filling pressures are. So this is asking them how short of breath are you and regressing it versus what the hydrostatic pressure in the pulmonary capillaries is. And you can see that there's a relatively modest but a significant relationship here, suggesting that there's a mechanistic relationship. And this is associated with an increase in inspiratory drive index, or estimated by the ratio of tidal volume to inspiratory time. They also have greater tachypnea. They have more rapid, shallow breathing. All of this goes with that increase in filling pressures. They have more dead space ventilation. All of this stuff seems to track with the elevation in wedge pressure. As your exercise wedge pressure goes up, your aerobic capacity goes down. And we see that this is a different study that's currently in review. Peak VO2 in the supine position, or even greater in the upright position, significant drop-off as those filling pressures are going up. And then this is data from Europe published a couple years ago. Even among people who have normal filling pressure at rest, if the filling pressure goes up during exercise, they have increased mortality. So it's associated with symptoms, severity, exercise capacity, and outcomes. So what do we do about it? How can we treat it? Lots of interest in this. In the field of HFpEF, we've kind of, largely from the work of Walter Paulus, begun to appreciate this new model that HFpEF is related largely to inability to synthesize nitric oxide and all the downstream sequelae from that. So that's believed to be related to these risk factors like obesity, metabolic syndrome, hypertension, lead to a global low-level systemic inflammation, which impairs NO release from the endothelium. Less NO in the myocardium makes the myocardium stiffer and more hypertrophied, and then that causes the high filling pressure. So this is the model. People have really, drank the Kool-Aid on this one. Like, everybody's all in, but the evidence is actually not as strong as as it probably should be. So I think we should really be thinking more, but there's a lot of interest in this. We've tested this in a couple ways. So this is the RELAX trial, which compared sildenafil, which is a PDE5 inhibitor. It's used Viagra. It's used for erectile dysfunction. Giving sildenafil decreases the breakdown of cyclic GMP, which is the downstream second messenger of nitric oxide. And sildenafil, we thought, would improve the cyclic GMP levels and give you more of an NO effect in patients with HFpEF. It didn't. It didn't work at all. It didn't improve exercise capacity. It didn't improve other surrogates like BNP. It didn't improve echocardiography. It just didn't work. But maybe it was not a PDE5 problem. Maybe it's not a problem with excess catabolism. So then we did the NEAT trial. And this was testing IMDR, isosorbide mononitrate. It's an organic nitrate that delivers NO. And we did a novel endpoint looking at accelerometry, so how much they're moving around. So if their filling pressures are lower, they'll probably be more able to like move around more. That was the idea. It didn't work. In fact, it tended to decrease activity levels a little bit. So seeming to argue against the nitric oxide hypothesis, but there's lots of other things that could potentially explain this, not the least of which is this might not have been the best drug. There's tolerance, there's pseudo-tolerance.
So when you do this, do they affect their blood pressure? Do they feel worse because of a lower
Great question. There was a modest, about a 3 millimeter average drop in blood. So that's not a big drop in blood pressure. But if you look at the hypertension trials, like a 3 millimeter drop is like a huge change on outcomes. So maybe that is important.
Yeah, but the other side of it is that's when they're resting. So then you're talking about making them more active.
That's
if
right.
I get up and I walk, that might drop their pressure even more and they don't feel good.
Absolutely, and I think, and maybe you could say, Paul, to this better, but I think that there are even, nitric oxide might have effects on central command in the brain that might inhibit activity levels. So it's dirty, it's unclear, but so far not good evidence, but there's still a lot of hope. Now there's a different way of going after this, and Mark mentioned nitrite. I've been very interested in this pathway. So when we think about nitric oxide, we always think about this NOS pathway. L-arginine is converted into citrulline and nitric oxide, oxygen dependent. But there are these other guys, nitrate and nitrite anion. And we used to think these were just inert byproducts of N-O-metabolism, but it turns out this is an important in vivo reservoir for nitric oxide. And these can be reduced back to nitric oxide. And this reaction is catalyzed by hemoglobin, myoglobin, xanthine oxidase, things that are all around in the bloodstream and the body. That reaction is enhanced when there is hypoxia or acidosis. So when is hypoxia and acidosis happen? All the time, every day. Exercise. So maybe this would be a targeted way to deliver NO precisely at the time of greatest need. That was the hypothesis that drove us to do this study. So we took patients who were going to our cath lab. This will be a recurring theme, me doing studies on people that I'm doing a clinical cath on, and I'm piggybacking on some physiologic studies. This is what we saw. We saw that there was compared to placebo, a modest reduction in resting filling pressures from IV nitrite. Nitrate IV is actually the cure, it's in ERs. That's the cure for cyanide poisoning. So we were able to give it on an IND exemption. So modest reduction in wedge pressure at rest, but this is what happened with exercise. Huge reduction. So instead of LA pressure going to 30, LA pressure goes to 18. Much more of a drop in filling pressure, much more improvement in forward cardiac output. I haven't talked about this, but even though cardiac output is usually normal at rest in patients with HFpEF, their ability to increase cardiac output is blunted. And we can bring that up with nitrite. And one of the gold standard ways is to look at the increase in cardiac output relative to the increase in metabolic demand, or VO2, and that acutely shifts up with nitrite infusion acutely. So this was very exciting. It seemed to be just what the doctor ordered. Can't give an IV medicine all the time, so there is this inhaled nebulized form of nitrite. So we tested that next in a study in the cath lab, same design, same findings. Mild reduction in filling pressures and PA pressures at rest, but a dramatic reduction during exercise. So this served as the preliminary data for the INDY trial, which was a multi-center, randomized, double-blind, placebo-controlled crossover trial. We finished enrollment. The data is locked. I'm actually going to unblind this week. So I'm still in a good mood for now, but it might not last. But we will test whether this improves exercise capacity and accelerometry and quality of life in people with HFpEF. This will be presented at ACC 2018. So is there any wood? This isn't really wood, but anyway. I'm nervous. Given the history of HFpEF trials, I'm very nervous, but this is lots of hope that this is going to work. But this is the sobering truth. Therapies that work in systolic heart failure, HFrEF, mostly neurohormonal antagonists, beta blockers, ACE inhibitors, ARBs, they've failed in this disease. So they're both heart failure, but they're very different in how they respond to treatments. Why? One of the reasons that's really caught on lately is that HFpEF is very heterogeneous. It's not just one disease. And this comes from Mark Pfeffer years ago now, but now really everybody is kind of coming to think that this is largely the case here. You know, we used to think that HFpEF was like we talked this morning about the little old lady's heart. You know, chronic hypertension, concentric hypertrophy, fibrosis of the tissue, high filling pressures, and that was it. But now we know when we look at the echocardiograms in these people, they don't just look like that. Some of the people have bigger hearts, some smaller, some look totally normal. There's all these different risk factors. They all interact in different ways, and when you just put all this group together and give them all irbesartan or something like that, of course there's probably some people that did get better, and some people maybe got worse, and overall it was a neutral trial. So maybe we need to do a better job of phenotyping. So what are the key phenotypes? That is a key unanswered question, but I have some thoughts on this issue. So one of them is people with pulmonary vascular disease and right ventricular dysfunction. So pulmonary hypertension is just high pressure in the lungs, is very common in HFpEF. It's about 80% of patients, and it's associated with adverse outcomes. When you have an elevated pulmonary artery pressure, the first victim of that is the right ventricle. That has to push the blood through the lungs. So what happens is your right ventricular shortening. This is a right ventricular fractional area change. It's kind of like EF, that you can see it goes down as PA pressure goes up in patients with HFpEF. You can see compared to controls, the whole relationship is shifted down. That indicates it's not just too high of a pressure, there's actually myocardial dysfunction too. But this is a very, very, very bad prognosticator in HFpEF. So as your right ventricle starts to fail, these are the people that have the worst outcomes, independent of the severity of the pulmonary hypertension. So this is part of the progression of the disease. So maybe this is an important phenotype. What's unique? Yeah.
Is it a right-sided problem? Is it a pulmonary problem, or is it just a left-sided problem that seems to be backing all the way up to the right side?
Probably a little bit of all of it, and I'll show some of that. There's some evidence that I'll show you that there is like kind of a sequence, a progression, but we've also seen even in the earliest stages of HFpEF, before they have pulmonary hypertension at rest, there's dynamic abnormalities in pulmonary vasodilation and pulmonary and RV contractile reserve. So that speaks more to a myocardial issue that is earlier on. So what's unique about it? Well, we've been interested in looking at this is more data it's currently in revision. We took patients with HFpEF, not the early ones, so people with high LA pressure or wedge pressure at rest. And you can divide them, so there's criteria for pH. So pH is defined by a mean PA pressure of 25 or above. 2 standard deviations of normal is 20, so this is actually more like 3, but that's how we define it clinically. So no pH, we have people with isolated post-capillary pH. So remember, your pulmonary pressure is equal to the downstream left atrial pressure plus the product of the blood going through the lungs times the resistance to flow through the lungs. It's just a rearrangement of Ohm's law. So you can have a high PA pressure because the downstream LA pressure is high. That's called post-capillary or passive pH. Those people, you just diurese them, the pulmonary hypertension goes away because the left atrial pressure goes down. But then there's also these people with HFpEF who have some pulmonary vascular disease. The chronic exposure to high LA pressure has caused some remodeling and some vasoconstriction. Now they've got a high pulmonary vascular resistance. So they've got both. They've got 2 hits. And that's the group that we think is a little bit different. That's called CPCPH, combined pre- and post-capillary pulmonary hypertension. I hate the term, but it's out there right now. So it's CPCPH until the next meeting that they don't invite me to. It's like it's a bunch of people in a room like come up with these terms. So we looked at these people, rest, exercise, hemodynamics, and measured gas exchange. So what did we see about them? So the presence of pulmonary vascular disease was characterized by a decrease in cardiac output, especially with exercise. So when we exercise, we need to increase oxygen delivery to the tissues, but cardiac output. You can see that your cardiac output goes up, so the dotted line is the CPC, the red straight line is the passive pulmonary hypertension, and the black is the no pulmonary hypertension. Lower cardiac output at rest, less ability to increase output during exercise. We think mostly because the blood can't get through the lungs here. Despite the lower output, the pressure in the lungs is much higher. This is the PA pressure flow relationship, and you can see it's shifted upward and it's steeper in these people with CpcPH. What does this do? Well, when we exercise, so remember, like, about 70% of our blood sits in veins and 30 is in the arteries, and most of it's all sitting kind of in the abdomen and the legs. And when you start doing exercise, your quadriceps are pumping, the muscle pump is returning all this blood back to the heart, and there's vasoconstriction of the veins and the splanchnic, you're increasing all this blood back, and that needs to go through the lungs. Cardiac output, the blood flow through the lungs goes up by 4 or 5-fold during exercise, and the blood volume in the lungs goes up by about 50% during exercise. So it's a huge load. What happens if you've got all this vascular remodeling in the lungs? Well, you can't get it through there, so it has to go somewhere. So all this blood's coming back from the legs, but it's welling up in the right atrium. Right atrial pressure goes through the roof in the patients with CpcPH, much greater extent, even at lower filling pressure or lower venous return. Remember, at steady state, your cardiac output going out is equal to your venous return coming back. So the heart can't accommodate for this. Now, remember that the right heart and the left heart share this space in the pericardium, and there's only so much space. And when all this blood is coming back, the heart is going to fill to the point where the pericardium restrains further filling. And then when you try to jam more blood into that right heart, what's going to happen? The septum is going to bow over from the right to the left, and the left heart is going to start to get underfilled. You can do a measurement called the transmural pressure to assess the true distending forces on the left side of the heart. That's the pressure that you measure with your catheter internally minus that external pressure, which we can estimate by the right atrial pressure. So that's the true preload of the ventricle. This is what happens as cardiac output and venous return goes up. There's an increase in left heart preload in patients with more isolated diastolic heart failure. So the problem in them is it's building up in the left heart because it can't accommodate this. But these patients with CpcPH, there's actually a decrease in transmural pressure. And if you did an echocardiogram, you'd see that their left ventricle is getting a little bit smaller because the right heart is so overloaded. And that's a totally different, distinct pathophysiology of these people. And if you regress the change in transmural pressure versus the change in that pulmonary vascular resistance during exercise, you can see that the people that fail to have a normal reduction in PVR, so the patients with more pulmonary vascular disease, have a greater drop. So they basically have Frank Starling failure on the left heart from a pulmonary vascular and right heart problem. It's the crosstalk between the two. So again, I think it's a different disease. So if you look at their cardiac output response, the no PH patients, terrific increase in stroke volume. The patients with isolated postcapillary, it's blunted. The patients with CPC, stroke volume actually goes down with exercise, even though the PA pulse pressure is going up. So very different pathophysiology. But it's not restricted, to get at your question. If we look at PVR at rest in patients with early stage disease, it's not abnormal. But if you look at reduction in PVR on exercise, it is abnormal, and there's a greater drop in PA compliance. And these things lead to an inability to enhance right ventricular function. How am I doing for time? Is that an indicator that I'm behind, or does anybody else hear that? Okay. Okay.
You hear something?
Give me, yeah. It's the voices are telling me. Yeah, I forgot to take my lithium. All right.
We're all good.
We're all good. Okay, so this early stage disease, there's still measurable abnormalities in the pulmonary vasculature and in the right heart that we can see even in the earlier stages. So an unanswered question is what happens longitudinally in heart failure? And this gets to your question as well. We looked at patients with HFpEF, mostly the earlier stage of HFpEF, and echocardiogram at study entry, and then a median of 4 years later. So longitudinal within patient changes. Very little change in the left heart. This is LV diastolic dimension, so LV volume doesn't change. There's a mild decrease in LV ejection fraction, but it's still totally normal. It's like 61 to 58%. This is what happens in the right heart over 4 years. 20% increase in RV area. Reduction in RV function. RV fractional area change goes down by 9%, threefold more than the changes in the left heart. No change in PA pressure. So they're gradually dilating their right heart. This might be the natural history of what happens to these people. This must much more common than we realize. We don't know. So the prevalence of RV dysfunction increased from 12% at study entry to 30%, over nearly threefold over just 4 years. And the development of RV dysfunction was associated with worse outcomes. So suggests that this might be an important therapeutic target and phenotype. So how should we target it? Well, we've been talking about autonomics and stuff like that. So we did this study a couple years ago. We gave dobutamine to people with HFpEF and to people with no heart failure. And intriguingly, we saw that people with HFpEF had a much greater reduction in PA pressure, which is kind of strange. And you could say, well, that's because their wedge pressure went down, but that wasn't why. Their PVR went down more, and their PA compliance went up with dobutamine. And it turns out that the pulmonary vasculature is richly innervated by autonomics too. There's alpha and beta. So maybe there's more tonic pro-alpha, less beta in the lungs, in the lung vasculature. And maybe that's why dobutamine was working here. We looked at, in the interest of time, I'm not going to go over this, but we saw that the improvement in RV shortening with dobutamine was more related to vasodilation rather to a contractile effect. So maybe beta agonists could work, but dobutamine's an IV medicine. It's an inotrope that's used in CCUs. It's not feasible.
How much did RV EDV go down with dobutamine?
We didn't measure EDV. That would have been good. We didn't measure. We probably could go back and at least get end diastolic area.
Because at higher doses, the
Yeah.
preload's reduced with dobutamine.
Yeah, that's a good thought. We didn't measure that, but we could go back and look at that. So beta agonists, maybe by working on the lung vasculature could work. So what's another beta agonist that we all use for asthma? Albuterol. Albuterol is a beta 2 agonist. Beta 2 receptors relax bronchial smooth muscle, but also vascular smooth muscle. So this is more data in review. Did a double-blind, placebo-controlled, randomized controlled trial in the cath lab. Typical patients with HFpEF, hypertensive, obese. The primary endpoint was exercise PVR. Again, this theme, you really need to stress the system to see the earliest stages of abnormalities. So we didn't do resting PVR, we did exercise PVR when the flow is increased through the lungs. And I think that's important. So here's the design. We did baseline hemodynamics, exercise hemodynamics, 20 watts so not a high level, but a good level for these people for 5 minutes. Took our measurements, rebase, and then we randomized them, again, double blind, no idea, to inhaled nebulized placebo or albuterol. And then we repeat it. And then we compare it between groups relevant to the baseline by an analysis of covariance. Primary endpoint, exercise PVR, no effect in albuterol within placebo. Compared to placebo, huge reduction in exercise PVR, 35% reduction. This was also associated with an improvement in PA compliance, a reduction in PA stiffness, and a decrease in mean PA pressure. This is the pressure-flow relationship before and after study drug in the placebo. It didn't change. In the albuterol patients, you can see that they are, the whole curve is shifted down and it's less steep. And note also that the cardiac output at peak is increased by about 20%. So you're really enhancing pulmonary vascular function, and you're improving forward cardiac output, which is an important determinant of exercise incapacity in these people. We actually saw no effect on wedge pressure, so that's a good thing. One of the theoretical concerns of getting a pulmonary vasodilator to somebody with diastolic dysfunction is going to overflood the left atrium, cause pulmonary edema, but wedge pressure didn't change. Even though exercise wedge pressure didn't change, the transmural pressure went up. That's because the right atrial pressure went down. So that for that same wedge pressure, you're getting more distension of the left heart, and maybe that's allowing for better utilization of the Frank-Starling mechanism. And in regression, it's just like the descriptive data, the physiological data earlier. Now with a change in PVR, the patients that enjoyed a greater drop in PVR had a greater improvement in transmural pressure, even though wedge pressure didn't change. So I think the next stage is to do a clinical trial in HFpEF of a beta agonist like albuterol or something like that. So maybe this holds promise, but specifically for these people with pulmonary vascular disease. Now there's a lot of other different phenotypes. There might be an ischemic phenotype. We know coronary disease is very common. It's in about 2/3 of patients. If you have coronary disease in HFpEF, you have worse outcomes. There's some signal that you might do better if you get revascularized. We looked in this study, and we saw that stress testing is what we use clinically to detect coronary disease. It didn't perform well. This shows here very high false negative rates from stress testing, even in patients with angina, so it wasn't so good to identify the presence or absence. 50%, almost 50% false positive rate on stress tests. So these people, they've got some angina, they get a stress test, it's abnormal, they go to cath, there's no coronary disease. We used to call this syndrome X. But maybe not. Maybe this syndrome F is HFpEF. Remember that not all ischemia is due to epicardial coronary disease. This is an autopsy study from Maggie Redfield. They took hearts of people from autopsy who were controls and HFpEF patients, and you can even see here, this is microvascular density is substantially reduced in these people. There's microvascular rarefaction that's correlated with the extent of fibrosis that they have. So maybe these microvascular changes are causing ischemia, even in the absence of epicardial disease. And there's a whole host of different studies looking at this, both in animal models and in humans. It's associated with diabetes, obesity, HFpEF. It's even evidence that it's associated with viral infections, parvovirus, which is very common, can infect the endothelium, and then radiation therapy we've talked about. Radiation is very toxic to endothelial cells, and radiation is a huge risk factor for HFpEF. So this might tie together a lot of questions. Do HFpEF patients become ischemic? Well, we don't know. We've been trying to get at this. We did a study again in the cath lab, patients that were getting a clinical cath, and we measured high sensitivity troponin levels. And you can see they are increased, very significantly increased in HFpEF patients. If you regress filling pressures versus troponin, there's a direct correlation, suggesting a relationship. If you exercise them, there's an increase in troponin. Troponin is a measure of injury. There is actually injury that develops and worsens during exercise, a single bout of exercise in patients with HFpEF. And this is correlated with the severity of their myocardial dysfunction. So this is the change in systolic function, or S' velocity. As your troponin goes up during exercise, there's less ability to enhance systolic shortening and diastolic relaxation, providing more strong evidence that maybe there is an ischemic component to this disease.
I forgot to ask you this morning, did you also happen to sample lactate or anything, some index of ischemia while you were doing this?
We unfortunately did not do that. We're doing that now, though. We're going to measure it in the coronary sinus, because normally, as you know, the heart normally consumes lactate. When it becomes ischemic, it spills lactate over into the CS. And we're going to measure that. I've done it on a couple patients, so we definitely see it. So I think that this is going to be an important player for a lot of people. We don't know why they're ischemic. That's a whole other question, but they probably are ischemic, at least several patients. There might be a stiff artery phenotype. This is one of Mark's studies. People with worse aortic and carotid distensibility have worse exercise capacity. We've related this to changes in arterial compliance. As your arterial compliance during exercise goes down, you have a greater increase in filling pressures and less increase in cardiac output. They don't look that different at rest, though. And we think that this is kind of how the system works. You got this heart that's ejecting blood into a stiff vasculature, but it's kind of meta-compensated at rest. No big deal. You're a little hypertensive. But when you, again, increase that venous return, the heart's trying to increase its output, that aorta can't store more blood. That's what arterial aortic compliance is. It's storing that volume without an increase in pressure. That gets exhausted. You get an increase in pressure wave reflections. You get prolonged relaxation, you get an increase in filling pressure, and this is shown down here in the increase in wedge. So this, some people seem to get more aortic aging. They get it more prematurely. Maybe calcification, maybe something like that, who knows? But this might be another important phenotype. When you think about stiffening, you think that it's like this irreversible change in the mechanical properties, but remember, stiffness can be modulated. So this is data with nitrite. Again, NO donor, and we see that at rest there's a significant reduction in arterial wave reflections, which is shown here compared to placebo. And during exercise, again, remember it works more during exercise, significant reduction in arterial elastance, that's the first one, EAI, an improvement in arterial compliance and a reduction in SVR. So maybe a lot of this arterial stiffness can be druggable and targetable with things like nitrite. Is there a peripheral phenotype? This is all going to be, Mark, you can come up here and do the rest of this talk now. Yeah, so remember the Fick principle. VO2 is equal to the product of cardiac output and arterial venous O2 content difference. And they're equal contributors. And in heart failure, we've always thought, well, the VO2 is low, it must be the cardiac output. But that's not always the case. You've got to make both measurements. And Mark showed 7 years ago now, that at peak exercise, the patients with HFpEF weren't able to increase that AVO2 difference, probably because they weren't able to utilize and extract that oxygen in the periphery. And that finding has been confirmed by Greg Lewis's group using invasive data, and we've related that to problems in the periphery. So this is DM, this is the diffusional conductance for oxygen in the tissues, in the muscles, and that is impaired in these patients. It wasn't directly measured, it was sort of a non-invasive estimate, or a non-direct estimate, but again, substantial 30% reduction. What would cause this? Well, again, Mark and Delane have shown this is looking at fat in the muscle, and there is an increase in intramuscular fat, even though subcutaneous fat isn't different. So if you've got all these fat cells that are infiltrating in there, that's going to impair your diffusional conductance of oxygen. And this is related to exercise intolerance in these patients. There's a reduction in the capillarity of the skeletal muscle in these patients with HFpEF, and that's also related to their exercise capacity. So these are other changes not related to the heart, maybe originally related to the heart and sedentariness that becomes, from high filling pressures, maybe also related to some of the underlying processes, the inflammation, the NO availability. We don't know right now. Do we have a treatment for the periphery? You guys should know this, right? Yeah, we do. Exercise training clearly works. And Mark showed that. We've known that it improves peak VO2. Mark and Delane showed it didn't work through the heart, though. It improves your peak VO2 because it increases your arterial venous oxygen content difference. So it's having salutary effects in the periphery, in the skeletal muscle, and the vasculature. Do we have anything else? What about pharmacologic treatments? Not so far, but this is not even in review. This is hot off the press. So we looked at our data. So this is looking at that gas transfer in the muscle, diffusional conductance, relative to placebo, significant increase with nitrite. So, in addition to helping the overall convective transfer of oxygen from the heart, maybe improving the microvascular delivery in the tissues. So another reason why we're very hopeful that this is going to work for people with HFpEF. Okay, this will be the last phenotype. We all have been thinking about obesity. We are all surrounded by the obesity epidemic. Obesity is associated with all cardiovascular diseases. But when you adjust for the other risk factors that go with obesity, like lipids and hypertension and stuff, the relationship between obesity and things like coronary disease or stroke goes away. But not for heart failure. That's what's shown here. The risk of heart failure keeps going up with obesity. So there's something specific about obesity, which is a potent risk factor for heart failure. Obesity accelerates cardiovascular aging. Now you could argue that HFpEF is just a form of accelerated cardiac senescence. I wrote that I called it presbycardia. It's like if you took a bunch of 90 or 100-year-olds and took them to my table of truth and put an echo on, a lot of them would have HFpEF. It's kind of where we're all destined to become. But the problem is when you get it at 60, that's not good. That's accelerated cardiac aging. We think obesity is part of that. This is a study back in Minnesota where we did 2 separate echoes and clinical exams separated by 4 years. And we saw that over 4 years there was a reduction in blood pressure because they were using more ACE inhibitors and chlorthalidone and all that kind of stuff. So according to the old idea, that should improve ventricular mechanics, right? Because it's all due to hypertension. That was not the case. EES stands for end systolic elastance. That's the stiffness of the ventricle during systole. EED is end diastolic elastance. That's the stiffness of the ventricle during diastole. Went up. This is just normal people. Community-based study. Went up by 10 to 14% over just 4 years' time. This is what's happening to us. Our hearts stiffen with aging. The stiffening is accentuated in the people who gain the most weight. If you manage to lose a little bit of weight, you don't stiffen. But if you gain, especially if you gain 4% or more of your body mass, you have the largest increases. And this seems to be greater for people with central obesity. And this is neck to height. There's a bunch of ways to look at central obesity, but this is really accentuating this. Obesity is becoming more of a problem in HFpEF. So this is just like older trials to more recent trials. The median BMI in Indy is 36. Class 2 morbid obesity, that's the median. There's hardly any patients below 30. And I know you guys are seeing it down here. We were talking about that earlier, Mark. I mean, Alberta HFpEF is the maybe non-obese, but everywhere in the States, I think it's a disease of obesity. So, okay, and we know obesity stresses the heart, does a lot of unique things. So we asked the question, is there a distinct obese phenotype in HFpEF? So we did a case control study, 266 patients, 99 obese. We took class 2, so BMI 35 or above, compared to non-obese HFpEF and non-obese controls. They all had invasive hemodynamics, they all had a comprehensive echo, invasive cardiopulmonary exercise testing, and then their clinical data. We just really kind of took a deep dive to try to phenotype them. This is what we saw. So as your body mass goes up, there's more right heart chamber dilatation. As your body mass goes up in obese patients, there's a greater increase in your left atrial pressure. So there's a direct relationship here between your extent of adiposity. But if you look at the non-obese patients, that relationship is not true. We also know from studies back in the 60s that blood volume and plasma volume increases with obesity. There's more volume overload. There's hyperaldosteronism that's due to obesity. So it's a volume load. So it suggests that this might be a unique and important difference here. And indeed, when we estimate plasma volume, as we did in these patients, we see that the relationship largely is explained by this. There's poorer exercise capacity. So this is the change, these bar graphs show the change in cardiac output with exercise. And it's actually not different in non-obese and obese patients. They both have a cardiac output reserve limitation. Both obese and non-obese HFpEF have to do more metabolic work to do ergometric work. So they have to burn more oxygen to perform the same amount of work on the pedals. And that's exaggerated even to greater extent in patients with obesity. Patients with obese HFpEF have a more profound increase in PA pressures on exercise, and it's due to greater reduction in PA compliance and an inability to reduce pulmonary vascular resistance. So they have abnormalities in pulmonary vascular function and right ventricular PA coupling. They also have an increase in epicardial fat. The fat is elsewhere, so it makes sense that it would be there as well, but that was substantially increased. And when you put together that chamber dilatation on the right heart, the hypertrophy that they get, and the increase in epicardial fat, the total heart volume gets higher. When your total heart volume gets higher, the pericardium, which contains the heart, has to grow too. If the pericardium doesn't grow as much as your heart grows, then it's going to increase the coupling between the right and left heart. They're both going to be competing with each other for a fixed amount of space. You can quantify that coupling, what's called diastolic ventricular interaction, by looking at the configuration of the septum. So here, this is the pointer on there? Yeah. So here's the LV and the RV. And normally the septum is convex towards the RV because the pressure in the LV is higher. When that diastolic interaction is increased, the septum becomes flat and the LV takes on a D shape. That indicates that there's more of this pericardial restraint. You can quantify how D-shaped this is by what's called the eccentricity index. And as that gets higher, there's more of this interdependence. And we see that that's increased in patients with obesity. And in the cath lab, what we see is that the ratio of right heart pressure to left heart pressure goes up. That's an indicator that there's more pericardial restraint. And this could have important implications for how we understand and treat this disease. Another thing that can increase this coupling between the two sides of the heart, and I showed you earlier, is pulmonary vascular diseases. Pulmonary hypertension gets worse, the right heart gets overloaded, and you get more of this coupling. That didn't explain it, but as your PA pressure worsened, there was a positive interaction here, so you became more and more eccentric with worsening pulmonary artery pressure load in these patients. Well, what can you do? We don't know much. We know this one study from Delane and Mark and others, the SECRET trial, where they randomized patients, mostly women, obese, to either attention control, 20 weeks of exercise training, caloric restriction diet or diet plus exercise, and you can see an incremental increase in weight loss that was also associated with a significant improvement in exercise capacity and quality of life. And the combination of diet and exercise was additive, although they were both significant compared to control. So lots of hope that we can target this somehow and make these patients do better. Still not understood well how that will happen. So in conclusion, hopefully I've convinced you HFpEF is fundamentally defined hemodynamically. We don't always do hemodynamics, but that is our core definition. A normal BNP and a normal echo and a normal exam do not exclude it. Invasive exercise testing is the gold standard. We don't use it on everybody. We should use it on people with an intermediate pretest probability of disease. There's no proven pharmacologic treatment. There's a lot of hope for things like nitrite, and we'll know more about that soon at ACC in a month. There's evidence that weight loss, exercise training, and diuretics are all helpful, and I think in the future, better phenotyping of patients based on pathophysiologic understanding is going to be the path forward, and I've shown some of these different phenotypes that we went through that I think are the keys to understand moving forward. So I'll stop there, and thank you very much for the invitation and your attention.
Thanks very much, Barry, for that tour de force there. That was amazing.